Professor Hiddo Heerspink. He is a professor of clinical trials and personalized medicine at the Department of Clinical Pharmacology and Pharmacy at the Medical University in Groningen. He was involved in a large number of clinical trials. He has authored extensively on the topic under discussion here. He is currently included, or he was included in DAPA CKD, FINE CKD, ALIGN, ZENITH, and Frontier trials. His main expertise is in trial design, personalized medicine, and methodological aspects and statistical analysis of clinical trials. Dr. Heerspink has authored and co-authored over 500 peer-reviewed publications, and he is on the editorial board of Diabetes, Obesity, Metabolism, Clinical Journal, American Society of Nephrology. And he's reviewer, of course, for a large number of journals. So with that, please join me to welcome Professor Heerspink, and he will talk about the impact of GLP-1 receptor agonists and Twincretins on CKD progression in subjects with CKD.
Thank you very much for the introduction. Good morning, ladies and gentlemen, or good afternoon. It's my pleasure to join you today and talk about not SGLT2 inhibitors, a topic I've been talking about a lot the last couple of years, but we are making progress in the treatment of chronic kidney disease, and we have a new, very interesting drug class, and actually many drug classes basically that are protecting the kidney, and we are currently testing them in clinical trials. And today I'm going to talk about incretins. You have already heard a little bit about the incretins, in particular semaglutide from Peter. I'm going to look towards the future, and I'm going to talk about, I call it the next generation incretins. And I'm going to show you what trials are currently ongoing, and then in the discussion we can talk about and think about the mode of action and what we can expect from these trials in the future. My disclosures are listed here. I work with a number of pharmaceutical companies to develop new drugs for patients with chronic kidney disease. And this is a summary that I wanted to show you to start off with. As you know, in the late 90s, early 2000s, we had the ACE inhibitors, angiotensin receptor blockers, and then for many years, although we tried many new drugs, they all failed. Not because of efficacy, but mostly because of safety problems. That all changed, as you've heard, in 2019 when the Incretins trial was presented, the first clinical trial in diabetic kidney disease that demonstrated that on top of ACE inhibitors and angiotensin receptor blockers, you can add additional protection, not only for the kidney, but also for the heart. At that same meeting, the SONA trial was presented, and although many people talked about the SGLT2 inhibitors, actually, the SONA trial demonstrated that the endothelin receptor antagonist atrasentan reduced kidney failure, reduced the risk of kidney failure by 35%, an effect size that is similar to SGLT2 inhibitors. But we haven't heard a lot about endothelin receptor antagonist until last year, probably because these drugs have one side effect, namely fluid retention, that can cause heart failure. And that's why we don't use them so often in patients with diabetic kidney disease, because these patients are at particular high risk for kidney failure. But now we are translating endothelin receptor antagonists to other patients, like patients with IgA nephropathy who are at an intrinsically lower risk of heart failure. And thus maybe these drugs are extremely powerful for these patients. And you will hear more about that on Saturday when I'm going to present the results of the ALIGN trial here at the conference. That is a clinical trial designed to test the hypothesis that atrasentan, the same drug as was presented 5 years ago in Melbourne at the World Congress of Nephrology, here at the ERA, in patients with IgA nephropathy. And you will hear more about that trial. We have heard about the MRAs, finerenone in particular, but we have new MRAs in development. Last week at the European Heart Failure meeting, the first results of the MIRACLE trial were presented. This was a clinical trial in patients with chronic kidney disease and heart failure, and demonstrated that in these patients with balcinrenone-dapagliflozin combination, you can markedly reduce albuminuria without any change in potassium. So combination treatment is going to be the future. Why are we developing all these combination treatments? Well, some people have said, we have SGLT2 inhibitors. We don't have to think about other therapies because SGLT2 inhibitors are so powerful, they protect the kidney. And of course, they are very potent. But let's take a look at this post-hoc analysis of the Incretins trial. In the Incretins trial, canagliflozin reduced albuminuria by 30%, as you can see on the left side in the graph. But there are still some patients with high albuminuria. You can see that on the right side. Here we see the baseline, the solid bars, and the number of patients at 6 months with certain albuminuria levels. So you see there is a shift towards the left after 6 months treatment with canagliflozin towards more patients in the lowest albuminuria category of less than 300 milligram per gram creatinine. But at the same time, if you look at the right side of that histogram, you also see that there are still many patients, in total more than 800, who have an albuminuria level more than 1000 milligram per gram, despite receiving canagliflozin. This is what we call residual albuminuria, the persistent albuminuria that is still present even during treatment with an SGLT2 inhibitor. Now, that residual albuminuria is still associated with a residual high risk of kidney failure, and that association is exactly the same as the association seen in the placebo group. And you can see that here on the graph, the black circles are the canagliflozin-treated patients and the white circles are the placebo-treated patients. If you look on the left, if we look at kidney failure, you see that the residual albuminuria shows an identical association compared in the canagliflozin group compared to the placebo group. The only difference is that the association in the canagliflozin group, the patients with residual albuminuria in the canagliflozin group came from a higher level. So let's say that a patient with an albuminuria of 1500 milligram per gram that received canagliflozin had a reduced albuminuria at 6 months to 1000 milligram per gram, whereas the placebo-treated patient who started with 1000 didn't change the albuminuria and stayed at 1000. That 1000 milligram of gram albuminuria has the same risk in the placebo-treated patient as in the canagliflozin-treated patient. And that is not only true for kidney failure, it's true for cardiovascular outcomes and for heart failure outcomes. And that tells us that it's not the SGLT2 inhibitor that dictates the residual risk, but it is the residual albuminuria that is responsible for the high risk. This also means that you have to further reduce albuminuria to less than 1000 and probably to 0 to reduce the risk of kidney failure completely. So what other therapies do we have that reduce albuminuria? Today we're going to focus on the incretins. And I'm going to tell you something about the GLP-1 receptor agonist. Probably you've heard the same story as Peter has told you. But then we're going to look at the novel incretins, the GLP-1 GIP receptor antagonist, the GLP-1 glucagon receptor agonist. And I do that every time in patients with type 2 diabetes, as well as in patients without diabetes who have overweight or are obese. We're going to look at GLP-1 glucagon receptor agonist. We're going to look at the triple agonist, GLP-1 GIP glucagon. And then finally at the GLP-1 amylin analog. So you have seen this meta-analysis already many times today. It's a meta-analysis of GLP-1 trials that demonstrate that GLP-1 receptor agonists can reduce the risk of kidney outcomes. But as you have heard already, these kidney outcomes, as observed in cardiovascular outcome trials, were mainly driven by reduced reductions in the risk of macroalbuminuria, which is a surrogate, and admittedly, we would like to see the effect on kidney failure by itself, but we don't have dedicated outcome trials until Saturday when the FLOW trial will be presented. But we know already from a semaglutide trial in cardiovascular disease patients that semaglutide, as shown on the left, reduces albuminuria significantly. And if we look at a pooled analysis of the SUSTAIN 6 and LEADER trial with liraglutide, we can see that indeed overall in the top graph of the forest plot there is a reduced risk of kidney outcomes, either defined by a 40, 50 or 57% decline in GFR. This effect seems to be more pronounced in patients with existing kidney disease, as you can see in the middle part of the forest plot, where the effect is presented in people with a GFR between 30 and 60 or high levels of albuminuria. And that is important because these patients are in particular high risk of kidney failure, and if the relative risk reduction is more pronounced in these patients, the absolute risk reduction is in particular high for these patients. And as GLP-1 receptor agonists also slow the progression of kidney disease, as demonstrated in this study published last year in Kidney International by Catherine Tuttle. Shown on the left, we see the rate of decline in GFR, and on the right, you see that the benefit is present in both people with an HbA1c above 8% and below 8%. And these data will be published these days as well in the Nephrology Dialysis Transplantation Journal. What is interesting, if we look on the left, is that it seems that GLP-1 receptor agonists, just like SGLT2 inhibitors, cause an acute decline in kidney function. But it's not so clear because these trials were mainly done in people with cardiovascular disease. And I'm very much looking forward to the FLOW trial and the GFR trajectories over time in the FLOW trial to find out if there is acute reductions in GFR, which are probably reflecting a hemodynamic effect, or whether these effects of GLP-1 receptor agonists are mediated by other mechanisms of actions, and Peter already alluded to them. And this is the FLOW trial. I don't have to mention that again, 24% relative risk reduction for the primary outcome. But most importantly, if you will read these reports and these press releases, always read the small letters in the press release or the last sentence in the press release, because that last sentence is probably why the trial was stopped early, because the trial also demonstrated a beneficial effect on all secondary endpoints, including mortality. Now, what about the effects of semaglutide in people without diabetes and obesity? There was a big obesity program already finished with semaglutide, not 1 milligram once weekly as used in the FLOW trial, but 2.4 milligram once weekly. These were 6 trials, I believe, in total, but unfortunately only in one trial albuminuria was assessed. We looked at the effect of semaglutide, 2.4 milligram, in patients in one trial, but this trial, semaglutide 2, also enrolled patients with type 2 diabetes. So this is a trial in obesity with type 2 diabetes. And as you can see, semaglutide 1 and 2 milligram, the blue bars, reduce albuminuria after 68 weeks of treatment, whereas the albuminuria levels increased in the placebo group, leading to significant placebo-corrected reductions of about 30%. But again, this is in type 2 diabetes. What about the effect of semaglutide in patients without diabetes and chronic kidney disease? Could it be that just like SGLT2 inhibitors, semaglutide is kidney protective in these patients? And that's why we designed the SMART study. And it was a smart choice to design the SMART study in 2019, when COVID just hit us, in 2020. It was a clinical trial investigator-initiated in 5 countries, Canada, Netherlands, Germany, Spain. And the trial has recruited 100 patients with chronic kidney disease who are going to be followed for 24 weeks and then continue into a washout period. The trial is fully recruited. The last patient, last visit will occur in 2 weeks, and we'll have the data in August this year. The nice thing of this trial is that we're testing semaglutide 2.4 milligram, but most importantly, we are measuring kidney function. So we're not estimating kidney function with creatinine or cystatin C, but we use iohexol GFR. And why are we doing that? You know that in the setting of significant weight loss, and we expect a significant weight loss with this drug, the muscle mass will decrease and that will affect GFR, creatinine-based estimated GFR effects. Then you could say, well, we're going to measure cystatin C. But what is the problem with cystatin C? Why do we have cystatin C in our body? Who knows? Yeah. So it has it is upregulated in people with obesity. Why? In adipose tissue, there is inflammation. And the body tries to reduce that inflammation, so you upregulate cystatin C to remove the inflammation. So that's why in obese people you see a somewhat higher cystatin C. Now, if we use a drug that reduces inflammation, and we expect that GLP-1 receptor antagonists reduce body weight, reduce inflammation, what will happen with your cystatin C? Decreases, yes. And what will happen with your estimated GFR cystatin C? Increases. So it affects your cystatin C estimates. At least that's the hypothesis. So although you would think, well, it's easy to use cystatin C in this setting, it's not so easy. What do we have left? How are we going to measure kidney function in the future in clinical practice when we're going to use this drug in these doses? Sorry? I don't know. No. Iohexol GFR, or maybe 24-hour clearance of inulin. So we ask the patients to stay in hospital forever, and then we measure kidney function all the time. So we have a problem in the future, I think, and we have to solve that. But it's nice because problems have to be solved. So it's challenging for research, and we're going to solve it. This study will hopefully be presented at the end of the year. So what about the new incretins, GLP-1 and GIP receptor agonists? There is one GLP-1 GIP receptor agonist, it's tirzepatide. It's one molecule that targets both the GLP-1 receptor and the GIP. 5 times more effective against GIP compared to GLP-1. So it's probably not a super GLP-1 receptor agonist. It really targets both receptors. This is the fourth clinical trial in patients with type 2 diabetes and established cardiovascular disease. These patients are at high risk of developing chronic kidney disease. And in this trial, tirzepatide was compared with insulin glargine treatment. And as you can see in the graph, over time, the albumin levels increased in the insulin glargine group by about 50%. And now you think, wow, that's a big effect. But remember, the starting levels were not so high. They were around 10 milligram per gram, so 50% relative increase is a modest absolute increase. But nevertheless, if you compare that with the changes in albuminuria in the tirzepatide group, you see a reduction in albuminuria with tirzepatide and a statistical significant difference between insulin glargine. Now, if we look at the effect during the washout phase, you see hardly any change from the last on-treatment visit to the end of the washout, but you'll see that the albuminuria levels increase again in the tirzepatide group, indicating that this effect, this reduction in albuminuria, is reversible when we stop the drug and thus likely reflects a pharmacologic effect. But more importantly, if we look at GFR slope and the trajectory over time, in the insulin glargine group you see a linear decline over time, whereas with tirzepatide, it seems that we see an acute reduction in GFR, followed by a stabilization, preservation of the long-term kidney function decline, a pattern that is reminiscent of SGLT2 inhibitors. Now, importantly, if we stop the drug, in the insulin glargine group, no change during washout, whereas the GFR is partly reversible in the tirzepatide group, supporting the idea that at least part of this initial reduction likely reflects a hemodynamic effect. Are these effects present in people with or without SGLT2 inhibitors? Yes. On the left, we look at albuminuria, and those using an SGLT2 inhibitor indicated by yes. they have a reduction in albuminuria, as well as in those not using an SGLT2 inhibitor. And about 25% of these patients, 2,000 patients in total, used already an SGLT2 inhibitor. And we see on the right that the effects are also present on GFR decline in those using an SGLT2 inhibitor. And now I'm coming back to my question, can we use these drugs and can we estimate GFR and can we still measure kidney function with cystatin C? Well, in this trial we also measured cystatin C, and you see that the patterns in creatinine-based eGFR or cystatin C-based eGFR are identical. I cannot explain this completely because my hypothesis was that both in creatinine and cystatin C cannot be used, but it seems that the effect is also present when we use cystatin C. Does that mean that that this is all explained by changes in body weight and all the downstream effects? We don't know because we don't have a true measurement, and that's why it's so important to conduct future trials with these novel agents and measure GFR to have a gold standard assay. Now, tirzepatide has also been tested in people without diabetes and obesity in the SURMOUNT program. And this is the SURMOUNT program where we assessed the effects on kidney function in the SURMOUNT-1 clinical trial. These patients that participated in SURMOUNT-1, and again a large clinical trial of 2,500 patients, had a GFR of around 90. So in general, they have no kidney disease, so we don't expect big effects on GFR because there's probably not so much GFR decline in the control group. So when we look at GFR changes over time, on the left we see the creatinine-based eGFR estimates, just like with tirzepatide in the type 2 diabetes patients. On the left, after 12 weeks of treatment, you see a drop in GFR, and then during the longer-term treatment, you see that the GFR estimated with creatinine slowly increases over time. Again, whether this is a true effect on kidney function or reflects the change in body weight, we don't know because we don't have true measurements. But interestingly, if we look at cystatin C-based eGFR, you see an increase in GFR, consistent with the idea that perhaps it's not that we increase GFR, but we just reduce the body weight size, we reduce fat, we reduce inflammation, and that's why we reduce or decrease cystatin C and thus increase cystatin C eGFR. Now, what about albuminuria? Well, there is a reduction in albuminuria as shown on the left in the overall population, but more importantly, if we look in people with established albuminuria, so micro and macroalbuminuria, as shown on the far right in the bar graph, you see albuminuria difference with placebo treatment of about 40%. So maybe these drugs can also be effective in people without diabetes and high albuminuria to slow the progression of kidney disease. There are no dedicated outcome trials with tirzepatide, unfortunately, to demonstrate a kidney effect. What about combined treatment with a glucagon receptor agonist? And we only have trials now in type 2 diabetes with or without chronic kidney disease. And this is Cotadutide. Cotadutide is a GLP-1 glucagon receptor agonist. A clinical trial in diabetic kidney disease was conducted and presented last year at the European Association for the Study of Diabetes meeting in Hamburg. And in this trial, Cotadutide was compared with placebo and semaglutide. And what you see on the right is after 24 weeks treatment, a dose-dependent reduction in albuminuria with Cotadutide in these patients. The highest dose of Cotadutide, 600 milligram, that reduces albuminuria by almost 50%, an effect that was slightly more than what was observed with semaglutide. And on the right you see the changes over time with Cotadutide in albuminuria. Now in this study they looked also at albuminuria alone, so not adjusted for creatinine, just because to demonstrate that even if you don't adjust or standardize for urinary creatinine, because there could be an effect on body weight, which could affect your urinary creatinine concentration, and they wanted to be sure that there was also an effect on albumin, urinary albumin concentration per se. You see that with semaglutide, dose-dependent reduction in albuminuria and not with placebo, and a smaller effect with semaglutide. How is that possible? And then we looked at creatinine excretion. No change in urinary creatinine excretion in the Cotadutide group. But strangely, if we look in the semaglutide group, you see an increase in creatinine concentration. Maybe that explains that smaller effect on albumin excretion. And thus it's important also to look in future studies not only on albumin to creatinine ratio, but albumin alone and creatinine concentration alone. Now moving on to the triple agonists, and these drugs have profound effects, as you've probably seen, on body weight and obesity. This is in type 2 diabetes and in patients without diabetes. Data presented at the American Diabetes Association last year and published in the New England Journal Medicine and in the Lancet, that demonstrated that this drug, this triple hormone therapy, retatrutide, significantly reduces HbA1c as well as body weight in these people. Now, what about these effects on kidney parameters? Will be interesting to see. I cannot disclose that information yet. You have to travel to the United States and to Orlando next month. It's a nice excuse to your boss to come to Orlando next month and tell your boss that you want to see these results that are presented at the American Diabetes Association. Then finally, GLP-1 amylin analogs, another new avenue to hopefully protect the kidney. I cannot pronounce it. Cagrilintide. It's a long-acting amylin analog that can reduce body weight through activation of homeostatic reward centers in the brain. It delays gastric emptying and suppresses glucagon release through alpha cells in the pancreas. And Phase 2 studies looking at HbA1c and body weight have already been performed. And in this study, published in the Lancet, you can see, again, just like the other incretins, profound reductions in body weight. No surprise, probably, if you directly target the reward centers in the brain, because these people don't feel hungry again and start to eat less. It delays gastric emptying, so your full stomach, you don't want to eat anymore, and it also suppresses glucagon release. Now, wouldn't it be interesting to look at these effects in people with chronic kidney disease to demonstrate that this drug could also protect the kidney? And that's why the sponsor and the manufacturer of this drug, it's a well-known manufacturer, Novo Nordisk, has started this clinical trial of combined treatment with semaglutide and cagrilintide in people with diabetic kidney disease. It's quite a big study, more than 600 patients who are going to be randomized to combined treatment with cagri-sema, semaglutide alone, cagri alone, and placebo alone. The trial has started, recruitment is ongoing, and we'll see more about the effect of this drug on kidney parameters in the future. Peter already talked a lot about the interaction between the kidney and the heart, and we all know that heart failure is one of the first and most common complications of chronic kidney disease, and there is a very close interaction between the heart and the kidney. Could it be that these new incretins could also be beneficial on heart failure, and then in particular in people with chronic kidney disease? The STEP trials were published last month, and they demonstrated that in people with heart failure, semaglutide reduces surrogate outcomes of quality of life, 6 minutes walking test, and a combined analysis of the STEP diabetes and the STEP obesity trials published in the Lancet last month even suggested that you can profoundly reduce the risk of heart failure hospitalization. So what about the new drugs, the new incretins, and their effects on heart failure? We don't know actually, but there is some supporting information. This is the STEP trial published in heart failure. And you see the Kaplan-Meier curves for heart failure hospitalization. As strong as SGLT2 inhibitors, I would say. And when I presented DAPA CKD, many people said, "Oh, Hiddo, you're so lucky. This is once in a lifetime and you're just at the right place at the right time." But maybe there's more than SGLT2 inhibitors with these new drugs. Now, what about the new incretins and their effects on heart failure? This is again Cotadutide, and look at the effects on the left on body weight, but also on NT-proBNP. Very small study in people with microalbuminuria, but you can see that NT-proBNP is reduced, suggesting that these new incretins may also have beneficial effects on heart failure, and we'll definitely see much more about this in the future. So, nutrient-stimulated hormone-based therapeutics, that's the new word people call these drugs. They target endogenous mechanisms that regulate body weight and energy homeostasis. These therapies consistently reduce albuminuria on top of current guideline recommended therapies. And although these trials are not performed and conducted in dedicated albuminuria trials, and even the albuminuria is measured single spot urine samples, it's not optimal, you can still see the benefit on albuminuria. These effects appear to be consistent in people with and without diabetes. And although in the past we've focused on diabetes trials, I think the future will look much more in chronic kidney disease more broadly, because many of the drugs that we're testing are beneficial for many different causes of kidney disease. But there are uncertainties, and I already alluded to them. What are the mechanisms for kidney protection? How do these drugs affect true GFR? How are we going to measure kidney function in the future? Not only in clinical trials, but you also in clinical practice. How are we going to do that? Well, there is this is my last word, there's a very interesting new methodology that allows you to measure kidney function at home in patients. It's transdermal GFR measurements. So you have a patient comes in the clinic, you give the patient, for example, a filtration marker, you inject the filtration marker intravenously, and then the patient goes home. The filtration marker is a transluminal filtration marker, so you can add a device on the patient's chest, and then it measures the signal. The signal is measured every hour for 4 hours, just like we do with iohexol in practice. And then the machine directly calculates the disappearance of the signal. And the faster the disappearance, the higher the GFR. The machine, the device will directly calculate GFR, will send it back to you, to the hospital, and you'll have the GFR. So this is, I think, how we're going to measure GFR in the future with these therapies. But we have to test that first in clinical studies, so still some work for me to do. And of course, importantly, what are the long-term effects of these new therapies? Is it safe to use a drug for many years where we see a significant reduction in body weight, but probably also a reduction in muscle mass, in particular in patients with kidney disease? Are we not going to induce frailty? Is it safe? Are there no effects on fractures? Come to the ADA and I will show you some data next month. Thank you for your attention.